Good evening, everyone, and welcome to tonight's CPD webinar, Non-Fatal Strangulation Supporting Patients in General Practice. Tonight's webinar comes to you from a consortium with 3 New South Wales PHNs, Sydney and Blue Mountains PHN, Central and Eastern Sydney PHN, and Hunter New England Central Coast PHN, in partnership with Women's Health New South Wales. My name is Lauren Gessock, and I'm the Domestic Violence Educator at Central and Eastern Sydney. So I'd like to start by acknowledging the traditional custodians of all the lands we're joining from today, and we do have people from all over New South Wales. So we'd like to acknowledge the traditional custodians of all those lands and pay our respects to First Nations people joining us this evening. So just a little bit of housekeeping. We do have the chat and the Q&A function enabled this evening. So please feel free to send your questions or use the chat to make any comments. We will be leaving questions to the end of the session. We are obviously dealing with some quite sensitive information tonight, so we want everyone to look after themselves. We have some numbers that we've popped into the chat. Please do whatever you need to do to take care of yourself. If you're feeling uncomfortable with the content and you do want to take a break, please do so or leave the session if need be. Okay, so I will now share. I'll just stop my I'll stop sharing just a second, and I'm going to introduce our speakers for the night. So I'm joined by 3 amazing speakers. I'm looking very forward to hearing from them. We have Courtney Artridge, who is a project officer at Women's Health New South Wales. She's working on a project that focuses on strengthening professional understanding and local capacity to respond to women experiencing non-fatal strangulation and acquired brain injury. Courtney's passion and unique understanding of the gendered nature of violence was gained from her work within the international humanitarian aid sector and project implementation in countries suffering from violent conflict, including Iraq and Yemen. Courtney's professional experience expands across a variety of roles, including nurse, security advisor, education officer, and pre-hospital care coordinator. We're also joined by Dr. Ellie Freedman, who is a sexual health physician with a career-long interest in women's health. She has worked extensively in New South Wales health, violence, abuse, and neglect services, providing trauma-informed medical and forensic care to victim survivors of sexual assault and domestic violence. She works as manager of the medical education portfolio, the New South Wales Education Centre Against Violence, overseeing the training of medical forensic examiners, and is also a senior clinical advisor to the Ministry of Health Parvan. And we also have with us Dr. Jamie Berry, who is a clinical associate professor at Macquarie University. He is a senior clinical neuropsychologist and mid-career researcher. He's also the Director of Advanced Neuropsychological Treatment Services, a private organisation that offers evidence-based assessments and interventions for people with cognitive impairments. He has worked extensively with working-age adults with brain-based conditions, including stroke, traumatic brain injury, and substance-induced brain injury, as well as victim survivors of domestic and family violence. He has led the development of cognitive impairment screening tools and cognitive remediation interventions that have been published in peer-reviewed literature. Jamie has taught on the clinical neuropsychology program at Macquarie University for over 25 years, as well as the programs at UTS, Sydney University, and New South Wales. So thank you so much for joining us, and I'll pass it over to you.
Thank you, Lauren. Part of our role at the Pathways Project, it has to connect with GPs, and that's because you're the main coordinating point for addressing the health needs of women with experiences of strangulation and those who are engaging in sexual choking. So a big thank you to the 3 PHNs for bringing us all together tonight, so both myself, Ellie, and Jamie can share some of our insights with you. So before we get into the discussion, I do want to just make a quick note note on language. So throughout the webinar, I will be using the term women, and that is to be both consistent with our remit at Women's Health New South Wales, but also because evidence shows that in the context of violence, it's most often women being the one being strangled. Okay, so Ali, let's start with you. So, when we're talking about women's health and strangulation injuries, in what context might they occur?
Well, I guess for me, and hello, Courtney, and welcome everybody. And I'm dialing in today from Camaragal land. I'd just like to acknowledge that. Um, and I guess for me, the whole kind of journey about strangulation started when we began to get case reports or information that strangulation, that women who'd experienced recent sexual assaults had high rates of higher than expected rates of carotid artery dissection. And the kind of link between strangulation and sexual assault started to be made. So a bit of a journey really for sexual assault services, which in New South Wales, medical forensic sexual assault services sit mostly within ED and work with EDs. So lots of conversations about the fact that we needed to ask people who'd experienced a sexual assault about strangulation. It's something that people often don't disclose for a lot of reasons, which most of which we'll touch on. Sometimes because they don't remember, and sometimes because they don't think it's serious or important. So we began to draw the link between sexual assault and strangulation. And as services started to ask all their sexual assault patients, their recent sexual assault patients, about whether they'd been strangled in the most recent assault. So sexual assault services tend to see someone within 7 days of an assault. We started to ask people about, did you experience strangulation as part of that assault? We discovered that it was quite a common thing. And then a few other studies which have looked at prevalence of sexual assault, prevalence of strangulation, have managed to kind of um, find more correlation, more kind of subtle differences in the sexual assault population. So within that sexual assault population, strangulation is common. Strangulation is more common in women who are sexually assaulted in the context of a domestic violence relationship. So began to become very clear to us that strangulation wasn't just a part of a sexual assault, but it was probably part of that pattern of controlling behavior and physically controlling behavior that happened in domestic violence. And we're beginning to understand more and more about how common strangulation is as a weapon of fear and control in domestic violence. So again, if we see people and they've had a recent assault as part of domestic violence, or they disclose domestic violence, we always ask about recent strangulation. We're concerned about acute strangulation injuries. But I guess the area that we're really beginning to pick away at and beginning to understand is that for many women, they've had ongoing violence and they've had ongoing subclinical strangulations and probably head injuries as well as part of either ongoing domestic and family violence or repeated different traumatic experiences, usually within the context of a partner relationship. And so we're really beginning to try and understand a bit more now about what the implications for women who've survived violent relationships are, what the kind of implications of repeated anoxia, repeated strangulation, repeated head injury are. So we kind of are beginning, we've kind of got some good models of care now looking at those acute strangulations happening often in the context of sexual assault or physical assault. We're thinking about the people who are living long term with the long term effects of repeated strangulations. And I guess the other groups of people we need to think about, if we think about when does strangulation present, there's also obviously accidental strangulations, self-harm. People may be strangled or choked if they're trying to hang themselves, which is, again, it's probably the only non-gendered form of, actually, I think men are more likely to strangle themselves as a form of self-harm than women are, but there you go. But also, I think we're increasingly concerned, and I know that in your work, Courtney, we've talked a bit before about consensual strangulation or sexual choking. And so again, we don't really, we haven't followed these groups of people up medically, but we know that sexual choking has really been normalized as part of sex, especially amongst younger people. And we don't know, again, whether that's even if they feel absolutely fine afterwards, what the implications of repeated strangulation are. And again, how are we going to find out? Because these aren't people who are presenting to emergency departments. So there's probably a lot more strangulation going on than we know about, and I think it's probably an important thing to always ask about.
Thanks, Ali. And I think it's important to support your response with some of the evidence on strangulation and sexual choking prevalence rates. And so, when mapping the evidence for the Pathways Project, we found there was limited prevalence data within the Australian context, which you've touched on. But what we did find was a 2021 study, and it found that 27% of women who had experienced coercive control also reported that their partner had strangled, choked, or grabbed them by the throat. There's also been 2 other studies published during this project, which I know Sarah's kindly put in the chat here for us. And so one was published just this February, and it reviewed strangulation deaths within Australian adults, and that was between 2000 and 2021. And that study found that 52.3% of strangulation deaths occurred in the context of intimate partner violence. And then there was the research paper that came out last year in July, which found more than half, so 56.9% of Australians aged between 18 and 35 reported having ever been choked during sex, so consensual sexual choking. So, Ali, as a healthcare provider, what does the July study that found the high prevalence rates of sexual choking among young people, what does that mean for you?
Well, I think it's really concerning. I think there's been, I think generally as healthcare providers, we're very bad at talking about anything that has sexual in front of it, whether that's sexual assault, sexual health, sexual choking. We really don't like to talk about sex in our professional lives. But I think that there's been a real normalization of sexual choking. And because it's seen as a normal part of sex, um, people aren't really seeing it as a health risk. And I think that's really problematic. You know, there's not much health messaging about what the risks of choking during sex are. Um, and when we talk about it being consensual or people consenting to being choked during sex, is it really informed consent if they don't know what the health implications are? So, putting aside maybe concerns about uh, whether or not people are really consenting to choking or whether they're just doing it because they feel that's what their partner or other people are expecting of them. Just in of itself, I think we need to be very clear with our patients or our peers or whoever else we're talking to that there's no such thing really as safe strangulation. Um, if you're being strangled to the point that you're having the impacts that are supposed to enhance sex so that you're disinhibited, you're hypoxic, you're causing small amounts of brain damage. Now, lots of things we do cause small amounts of brain damage, holding our breath underwater, which we all did as kids. Lots of the sporting things we do have a small risk of brain damage. But if people really understand that repeated anoxic episodes during sex are putting them at risk of both acute brain damage, but also long-term brain damage, um, then I'm not sure that they would be quite so happy about engaging in sexual choking. And I think that we need to really use a harm minimization message. We really need to engage in the conversation with people about the risks of sexual choking, because if we don't bring it up, and again, it's not necessarily an easy thing to bring up, but if we don't bring it up and if we say that sexual choking is a normal part of sex, then we're really saying that it's not a risk. Um, we don't know what the consequences that we know that over half of young people report choking during sex. We don't know what the health implications for those people are. But I do know that most of those people who are being choked during sex have not really thought about possible health consequences of that. I think people know that there's kind of a very small risk if there's not a safe word. If you don't stop choking me in time, there's a tiny risk of death, which happens to people who get it wrong. But I think even for the people who are having successful, safe sexual choking, it's not really safe. And I think that we need to be very clear about that messaging.
Yeah, yeah, absolutely. And Ali, you spoke about this a little bit at the beginning when we were talking about the context, but when should a GP screen or ask about strangulation, and when should they ask about sexual choking?
Yeah, so I think given that we know that huge overlap between sexual assault, domestic violence, and strangulation, I think we should be asking anybody who we know has been assaulted, especially in an intimate partner relationship, whether they experience strangulation as part of that assault. So we're interested. I mean, we need to know about the people who've experienced recent choking because they could have they may have acute damage to the great arteries, to the brain, to nerves that we can actually look for and possibly manage. But we also need to think about people, as I said before, who've had repeated episodes of choking and strangulation. So it's not simply that if you don't ask someone within 48 hours of the episode, you've missed the boat. It's less clear for us when people disclose strangulation that's happened in the past, what our pathway is, but it is important to identify that and just to make sure that we're thinking about possible brain damage in those people. So I would say anyone who you know who discloses sexual assault, domestic violence, we need to ask about whether strangulation happened as part of that. Um, of course, as well, if people present with symptoms of strangulation, it's not really screening then, it's making sure that we're taking a proper history. And if we're identifying strangulation, asking them about sexual assault and domestic violence. So making sure that we're making that linkage. Screening for sexual choking is really hard, isn't it? Because we think the majority of these people aren't asking for health advice. They aren't coming to see us because of anything else. Um, and young people, particularly, aren't necessarily great at either going to see their doctor or going to see a regular doctor. But I suppose I'm thinking about this from my sexual health background and thinking about it from the context of how we ask about lots of things in that reproductive age group. So if someone presents to us for anything as a young person, we might slip in some questions about STI screening. Have they done a chlamydia test? If it's a woman, we might be asking about PAP tests in the older, younger people. Um, and we might be asking about contraception. So we might also, if we're happy to, ask a few questions about their sex life in general, checking in about consent, checking that they're not in an unsafe relationship. And if this conversation is going swimmingly, and this might not happen the first time you meet someone, we can say that we know that sexual choking is a really common practice amongst young people. And is that something um, that they're concerned about? We don't have to say, is that something you do? We never have to ask people that, but we can just talk about the fact that we read the research that it's really common and we're really interested because we're worried about harm. And is that something they're concerned about? So I think it's these, as I said, talking about sex is really hard. We need to ask permission to ask those questions, but by us talking about it, we're setting a very clear message to our patients that these things matter to us and that we think that they're important. So I think if we don't bring it up, no one else is going to.
Yeah, and I like that final statement there. If we don't bring it up, no one else is. Jamie, my next question is for you. So we understand that strangulation and sexual choking, they can cause a brain injury. So be that an anoxic hypoxic brain injury, a stroke, or a traumatic brain injury when other forms of violence are used alongside strangulation. So from this perspective, what neurological signs and symptoms should prompt GPs to investigate associate experiences of strangulation or sexual choking? And would this look different, for example, if it was an acute injury versus one that was more historical?
Sure. Thanks, Courtney, and thanks for having me. I'm also joining you from Camaragal land tonight. So there are multiple mechanisms that could lead to acquired brain injury in this situation. You've mentioned traumatic brain injury or stroke or hypoxic brain injury. Now, each of those might manifest slightly differently in terms of the neurological and neuropsychological sequelae. But in general, one would be looking for general neurological signs, things like motor and sensory signs, weakness, motor incoordination, paresthesia, so tingling or numbness, visual disturbances might be a sign. It's also important to look for changes in things like speech and language, slurred speech or speech that doesn't make sense. And this would be particularly easy to recognise if the practitioner has an ongoing relationship with the person, because clearly they can tell when something is a change. Obviously, presence of seizures, particularly first-time seizures following an event, might be an indicator. In terms of the more cognitive or neuropsychological signs, a person might appear more forgetful in their everyday functioning. They might be slower in their thinking and a bit foggy in their thinking. That's been reported in the literature. They might struggle to keep track of a conversation, so they might lose their place in conversation. So these are things that might be signs that a practitioner could pick up during a consultation. In terms of the symptoms that are reported, and there is a literature, there was a systematic review published in 2022 that focused mostly on symptoms, and sadly it had to focus mostly on symptoms because the reviewers couldn't identify any single study that had done prospective cognitive testing. But the symptoms that have been reported in the literature include things like memory problems, difficulties concentrating, difficulties just getting daily tasks done and keeping track of things. It could be keeping track of bills or activities of daily living. The person might also describe changes in their personality or their emotionality. They may become more tearful than they were, which could be an indicator of emotional lability. Of course, that could also be an indicator of a psychological response. And it's very hard to tease apart the organic from the psychological factors, but it is possible that heightened emotionality in the form of emotional lability could be an organic indicator of brain damage. The person might report having a shorter fuse, and other symptoms that are often reported include fatigue. Fatigue obviously is not always physical. Mental fatigue is actually a common sequelae of acquired brain injury. And so a person's likely to become mentally fatigued when they're investing mental or cognitive effort into a task. That could be having a conversation or watching a movie. So if a person's reporting that they're feeling more tired, even in the absence of physical exertion, that could be an indicator. There are other neurological signs, of course, such as headache and dizziness and things like that. In terms of the difference between acute and chronic presentations, so the acute presentation aspect can be complicated in that not all the signs are present immediately following an event, and some can take, a few days or a week or even a couple of weeks to evolve. There have been documented cases of dissection or stroke occurring sometime after an event. But obviously with the acute presentations, that they will be a little bit more stark and obvious. And as Ellie has stated, there are medical investigations that can be more sensitive to those more acute presentations. And in terms of the chronic presentations, that's really a lot more fuzzy. It's fuzzy because of the multiple mechanisms of potential injury. It's fuzzy because self-report in a person with intact cognition is highly unreliable, let alone self-report of someone with known or suspected cognitive impairments. And I've certainly had patients who have missed major neurological events when providing a detailed history in the context of a neuropsychological assessment. So we can't always rely on the history that we gather from the person directly, notwithstanding all the other barriers that there might be to reporting, such as Ellie has mentioned. People don't want to talk about these issues frankly, or won't spontaneously do so easily in many cases. So again, the literature is not very clear on precisely how the cognitive or the neuropsychological factors might stack up over time, but it's highly likely that they would. We know that at least from the sports concussion literature and the general concussion literature, that the more concussions a person has, the more likely they are to exhibit cognitive impairment. So in the chronic phase, I think the signs and symptoms are similar, but I suppose the main difference would be that the person would be reporting that these changes have evolved over a period of time rather than in a stepwise fashion after a specific event.
Yeah, thanks for that, Jamie. And certainly one of the things that we focused on when we're in the Pathways project, when talking to other service providers, is reminding them that there can be this overlap. So counsellors, if they have post-traumatic stress disorder, but they have a mechanism for a potential brain injury, could they both be playing a role here as well? So yeah, it is very complicated. So we understand that there are many barriers to disclosing domestic abuse, including but not limited to shame, fear of child removal or fear of the perpetrator, poor service responses in the past, and financial barriers. So these are the same reasons that can also prevent women from asking for help after strangulation. Screening can let patients know that you're ready to have a conversation about violence and that you're a safe person to disclose to. So, Ali, this question's for you. So, what terminology considerations can help patients overcome barriers to disclosing strangulation that occurs in the context of violence?
Yeah, and I think that if we're able to do all the things you've mentioned, Courtney, if we're able to start that conversation talking about violence, then we've created that safe space. And as you guys online all know, that it's much easier said than done. It happens within a relationship. You get to know the patient, and generally, once they have judged you to be a safe person, that's when they're probably able to speak about some of those things. Um, so if we've kind of started to talk about, we know that we're dealing with a someone who's currently experiencing or has experienced domestic and family violence, then moving into those conversations about specifics and about strangulation is a kind of another step into a relationship that hopefully is already trusting and we've built. I think it's important to recognize that in addition to the barriers that you have um, described, Courtney, and I think certainly there's a lot of shame around strangulation, but in addition, there's additional barriers or reasons why people might not disclose strangulation. One is, of course, that strangulation itself, if people are strangled to the point of loss of consciousness, then there will be some loss of memory of the event. And certainly people will remember the beginning, may remember the beginning of the strangulation event, but if they're unconscious afterwards, then they will have an amnesia for that period. So it may not be significant in their memory as the most overwhelming thing that happened. And secondly, I suppose going along with that, people might not see it as significant. We're very concerned about strangulation for all the reasons that Jamie's detailed. We're concerned about acute neurological and chronic neurological issues as well as damage to the neck. But people may not think it's a significant part of it. And I suppose the other thing which goes along with that is if you think about people who are navigating their ongoing safety and they're navigating often the safety of their children and they're kind of living with a violent partner, um, the strangulation may not be number one on their list of priorities. So again, I think we do have to explain to patients why we're worried about it. We're worried about it because it could be medically significant, and of course, it's a marker of seriousness or a predictor of serious injury in the context of DV. So we need to explain all of that. And then to actually answer your question, Courtney, which I realize I've talked all around, the other thing, so the other reason why people might not disclose strangulation is because they might not call it strangulation. So people have a very clear idea that strangulation is two arms around the neck like that, but there's lots of things, anything that puts pressure on the airways and the great vessels is going to have the same impact. So we could say things like, was any pressure put on your neck? Were you unable to breathe at any point? So we're thinking about people being strangled with hands or strangled with a ligature. I've definitely had quite a few patients where someone has sat on their neck or chest or put pressure on them. If you think about holding someone in a chokehold, so down on the ground, that has the same mechanism of asphyxiation and pressure that can cause those same impacts. So making sure that when we're talking about non-fatal strangulation, we're talking about a range of mechanisms that can cause that anoxic damage that we're really concerned about.
Thank you, Ali. And of course, when we're considering consensual sexual choking, we understand that for many, sex is a very deeply personal and sensitive topic. And you did touch on this at the beginning, mentioning that we don't like to talk about sex. But I guess, so Ali, would you suggest GPs use different language when screening and providing health promotion about sexual choking?
Yeah, I think we do need to recognize that for most of our patients, when they're talking about strangulation in the context of an assault, it's a very different experience to strangulation in the context of consensual sex. And, like whether we even talk about assault as the sexual assault as sex, is that whole other conversation. So if we think about it in that way, people are doing something that they are getting some kind of enjoyment out of, whether that's because they're with the person they want to be with or because of the act themselves. So I think when we're talking about sex, we need to be very careful that we are using that kind of health promotion, harm minimization approach. So we're not saying don't do it. We're not saying get out of there. It's an unsafe space. We're talking about people's sexual preferences. We definitely need to ask permission to talk about people's sexual preferences, but we also need to share the concerns that we have at a population level. And certainly, if we saw a patient who had any signs or symptoms that were suggestive of sexual choking that came up in a consultation, I'd be very concerned that someone was being consensually choked during sex to the point that it had caused voice damage or memory damage or any of those things. So I certainly think we need to tread in some ways more carefully with the people who are experiencing sexual choking because they're not seeing it as a harm. And we need to be able to separate the sexual choking act from the rest of their sex life and probably from their relationship as well. So I do think it's really, really important that we do check that people are not um, trying to disclose a sexual assault or non-consensual sex or being coerced into sex as well as the strangulation. But if we're very clear on the consent piece, we still need to talk about the health risks and the harm and support them in trying to work out what a way of maximizing their sexual pleasure and minimizing the harms from strangulation is. And I suspect for most people that's reducing the frequency or the severity of strangulation.
Yeah. So at the Pathways project, we suggest using more benign and general questions about pressure being applied to the neck or being held so you cannot breathe, to help avoid confusion about terminology and potential minimization by victims and survivors. And so, Ellie, you already mentioned some people don't recognize strangulation as pressure to the neck and they may call it something else. So what was interesting was at the women's health centres we work with, this approach, it's already producing results. So when we first visited one of our women's health centres that's down south, they told us that they saw very little strangulation. After our training, the centre changed the way they ask clients about strangulation. So now they ask, was pressure applied to your neck or were you held in a way you couldn't breathe, even during sex? And what they found was women would usually start to shake their head until the questioner got to the even during sex, and then they would nod yes. So 4 months on, for one of our workers we trained at that centre, she tells us that that 90% of the clients she sees have experienced strangulation. So some of the women's health centres have adjusted this question, and particularly the even during sex part, to even during intimate times, to work better with particular groups of culturally and linguistically diverse women as well. Another technique that's also been used by our women's health centres is putting up posters in waiting rooms and bathrooms. And in some cases, this has prompted clients to bring up strangulation and sexual choking with the service provider in the consult. You can find a print-ready version of the poster that I've mentioned on our website, and I'm sure Sarah's going to drop it in the chat for us as well. Jamie, this question is for you. So when working with patients who potentially have an acquired brain injury from strangulation or sexual choking, do you have any comments about how language and screening might need to be modified by GPs?
Yeah, sure. I think it's important that that language is modified, and this is because cognitive impairment creates a bottleneck on information processing. So you can't assume that the person will even register, let alone remember the information at the beginning of the question or at the beginning of the conversation. So it's good to have some redundancy in communication with some repetition. Obviously, not to overdo it, but to repeat questions or ask them in a couple of different ways to give the person an opportunity to process it, and also an opportunity to take some time to formulate their response. As we've been discussing, some of these questions can be a bit confronting or unexpected, and so it might sort of take anyone by surprise, but especially if someone's got cognitive impairment, they just may need a little bit of extra time to process the information. So adding in a bit of redundancy and repetition can be helpful. It's also important, though, to use very simple language, very plain language. Short sentences is a good general rule. This is because sometimes immediate auditory attention span can be constrained in someone with an acquired brain injury. So they may only take in about 2 seconds worth of information at any one time. So if your sentence takes 5 seconds, they might only be getting 2/5 of your sentence and not be able to fully process it. It can also be helpful to provide some examples. So the sort of language we've been talking about is actually quite concrete. So when you say non-fatal strangulation, that's quite an abstract concept in many ways, but applying pressure to the neck and being more descriptive and concrete in language, I think, is helpful for someone with known or suspected cognitive impairment. So yeah, giving those everyday examples. It's also good practice when dealing with someone with a known or suspected cognitive impairment to give them some closed questions as well as open-ended questions. I think open-ended questions are fantastic to get a person's unadulterated, unfiltered views on a particular topic or what you're interested in. But sometimes people with acquired brain injuries can find that daunting and overwhelming. It's just too much for them to hold in mind at once, to formulate a response spontaneously. So when you give some options, some closed questions, yes or no, or choice of three, that is good practice in terms of communicating with someone with a known or a suspected acquired brain injury. So yeah, they're the main tips and pointers I would give on modifying the language.
Oh, I think they're great tips. There was something there that I hadn't thought of before. So thanks, Jamie. So the women's health centres that we work with, they've found some of the barriers for women who might have an acquired brain injury from strangulation or sexual choking relate to both accessing the mainstream health system, so keeping track of appointments and attending appointments, and getting the help they need. To assist women accessing healthcare services, we did produce a medical referral letter, which is designed to help women to communicate to health professionals any signs and symptoms that she may be experiencing and the impact she feels that the strangulation event has had on her day-to-day functioning. Again, you can find this resource on our website. So, Ali, this question's for you. After a disclosure of strangulation in the context of violence, what is a GP's next step?
Well, I think the first step when anyone discloses violence or is just to do a safety check, just to check that the person sitting in front of you is safe. And so, it's such a huge word, isn't it, safety? So I'm interested in, first of all, what's happening at home. Is there a safe place for them to go to when they leave your consultation? Are they at immediate risk of further violence from whoever has caused the violence? Are they psychologically safe? Which, as psychologically safe as someone can be. But I guess also immediately I'm thinking about have they got any medical red flags or issues that I'm concerned about. So this is more in the context of someone who discloses a recent strangulation. And then I'm kind of asking about some of the things we've touched on. Have they got any neurological damage? Have they got a permanent headache? Are they having pain swallowing or difficulty breathing during the recent strangulation? If it's a recent strangulation, did they experience incontinence? Have they got any changes in vision? Have they got any ringing in the ears? Things that kind of, to me, are possible markers of an acute brain injury and acute neurological injury. So I'm concerned about their physical safety, their psychological safety, and their medical safety. If I have any concerns at all, we're very happily able, generally these days, to send people along to the emergency department for hopefully an assessment. Um, I think right at the beginning, I was saying that our journey working in violence, abuse, neglect, working in sexual assault services, about the recognition of strangulation being a risk, a risk associated with sexual assault. The emergency departments have come a long way, have come on a lot of that journey with us. So, I remember when I was first reading about this and talking about this, I remember chatting to one of the ED staff specialists, and I said, "Oh, do you see any carotid artery dissections in people who've been strangled?" He said, "No, but it's strange. We do see carotid artery dissections in young people, and sometimes they've like been in an assault." And I was like, "Yeah, well, those could be the same people." So I think that EDs, again, we've all come on a journey about really recognizing how common strangulation is, especially in intimate partner situations. And EDs have got really good at assessing and managing strangulation. So really, we should hopefully be able to send our patients who've had an acute strangulation event. And for that, I'm going to pluck a figure out of the air and say in the last 7 days. If we're worried about them, then we can send them to ED. They'll do a further history and examination, they may get imaging, they may get to see a neurologist or an ENT person or whoever the appropriate specialist is. They may get assessed by ED as not having any of those risk factors and get sent home with hopefully some reassurance both for the patient and for yourself. So safety, safety, safety. But luckily, EDs are really, on the whole, on board with managing strangulation these days.
Yeah, yeah. And I also think along with that, those emergency departments, for those who have a Medicare, there's free access to that imaging as
Absolutely.
well.
And also if you're a victim of violence, victim services, you get free healthcare. So certainly for patients, in the sexual assault service, we have a number of patients who don't have access to Medicare. They have access to free healthcare if they're presenting to the ED as a result of a crime, of a violent crime, and they don't have to have necessarily made a police report. They've told the hospital, they've told the healthcare workers. We can advocate for those fees to be waived under victim services schemes.
Yeah, great. That's great. So, Ali, so what clinical guidelines support this response for
Well,
GPs?
so for GPs, there's a health pathway at the moment. There's a health pathway that's been written with I always get this wrong. I was about to say Southeastern Sydney, but it could be Southwestern Sydney PHN, and I'll be told off because I should have looked this up before I came. With Ministry of Health, PAVAN, Prevention and Response to Violence, Abuse and Neglect Department. There's one on adult and child strangulation. So those are really helpful guidelines. We're very guided in New South Wales, particularly by the Emergency Care Institute guidelines for management of non-fatal strangulation. It's a really, really useful resource. It's written in very plain English. Again, it's written very much, it was written in consultation with Ministry of Health, PAVAN department. So it's kind of got quite a lot of information again about the various contexts in which strangulation could happen, but it's got really clear pathways on acute assessment and management of strangulation. So if we see someone who's been recently strangled, then we've got the ECI guidelines. Although they really were designed for emergency care physicians, they're really helpful for primary care physicians as well. And if Sarah doesn't pop them on the chat, I can send a link out to you guys to circulate. But you can actually just Google them, ECI, non-fatal strangulation guidelines. The problem we have, and as Jamie said, it's really difficult, is the people who we think have got an acquired brain injury. They've had probably repeated strangulation or head injury events in the context of domestic and family violence, in the context of ongoing violent episodes. They probably do also have some history of psychological trauma, inevitably, and they may also have other confounding factors like drug and alcohol use or other mental health diagnoses. So the way of that, there's no clear guidelines to support the people who have kind of chronic brain injury, which is probably mainly as a result of repeated strangulation and head injury. And we're very much trying to understand this space better. There's a whole heap of different research projects going on, looking specifically at the domestic and family violence population, because the clinical research that we're backing much of our response on at the moment is sporting injuries. So we're not really looking at the right population to understand what the clinical guidelines are. So no good clinical guidelines in the chronic space, but I think watch this space, because it's very clear to clinicians and researchers that we need to understand what clinical interventions are helpful for these women.
Yeah, thank you, Ali. Ali, I want to talk now about the GP's role in supporting a woman's psychological needs. So, what is that?
Oh, well, I think we've talked about this a bit, haven't we? Because we've talked about the fact that what we're really aiming to do always is create that safe space where people can talk about domestic and family violence and about what's happening to them. And if we can do that and see the patient as regularly as we and they can manage, and in this ideal world of an increased Medicare rebate bulk bill for that, then we're achieving a lot just by forming the relationship. We know that safety and healing occurs within a trusting relationship. So that's to my mind, the biggest thing that a GP can do in terms of psychological support. Someone who knows, but someone who's experiencing domestic and family violence, and don't forget the huge psychological gaslighting impact of coercive control and being told you're worthless the whole time, being able to come in and see a GP and have someone who actually listens to what you have to say is pure gold. It's invaluable. But obviously, there's a bigger role than that. So GPs are the coordinators into specialist services, into specialist mental health services, if possible, into allied health services. So often people need psychology support. They might need OT and physio if they've got some motor impact. So that was not about psychological support, was it? But we can coordinate all of those supports. And we can organise for people mental health care plans. We can organise if there's a documented incident of violence, for crime. We may be able to organise victim services counselling. So there's free sessions through victim services. So there's GPs are also very well placed to coordinate support for patients. But the biggest thing, as I said, a GP can do is just regularly check in with someone.
Yeah. And Ellie, you started to touch on it a little bit when you spoke about victim services, but if we're now, what role do GPs have when they're addressing the legal
Oh,
needs
yes,
of
sorry.
women?
Yeah, look, I think this is such a difficult area because we don't, as GPs, we don't have a mandatory report. We don't have we're not making mandatory reports about a woman who's experiencing domestic and family violence. So unless we have absolutely overriding concerns about someone's safety, we're not going to phone the police without the patient being involved. We need to check in with the police, with the patient really regularly about whether they need more support with their safety, how they're keeping themselves safe, if they think this is a point that they want to involve police. We may need to make a mandatory report if there are children in the house who are impacted by the domestic violence. We might need to make a mandatory child protection report. But other than that, we don't need to make a report about the woman herself. And that can be really difficult because we may have a lot of concerns. So what we need to do is share those concerns with the patient and make sure that they have that we're talking with our patients about safety planning. So we're talking about with them about if they were to leave, where they would go, that we're making sure that they're getting copies of all their legal documents, that they're telling a safe person, a neighbour, about what's going on. So there's someone who they can reach out to. The other really important, so police is really up to the patient, though that can be a difficult tightrope to walk. But the other thing, of course, is community legal services, which can be really helpful in supporting women through the maze of family law and understanding their legal rights if they are to leave a domestic violence situation or to stay in a domestic violence situation. And my touch point for that is Women's Legal New South Wales. They wrote the very brilliant GP toolkit, which I'm sure many of you have seen. That's absolutely fantastic. And it's got some really clear practical advice on talking to your patients about domestic and family violence and reporting. But women themselves can also access the Women's Legal New South Wales website. They've got really clear advice. So there's a whole heap of really useful legal resources that a GP can share with patients who need them.
Yeah, thanks, Ellie. And I know that Lauren is going to talk at the end of the webinar a little bit more about some of the resources and supports that are available for GPs to help them connect patients with the broader domestic, family and sexual violence sector. So Lauren, I won't steal your thunder and I won't chat about that now. So Ellie, I do have one more question before I'm going to ask Jamie a question. And this one is really about how this response differs when we're responding to women who engage in sexual choking.
Yeah, and I think it's same but different. So we want to give people a heap of resources. We need to we'd like to give people a heap of resources rather about the health risks of sexual choking, but they're not out there. So we can give people lots of resources about domestic and family violence. There's very little we can give people about sexual choking. We do all agree we need to create one. So we just really can't really refer people on in the same way. But I think the same bit is that we need to create that safe space. So we need to make sure that we're making a different kind of safe space, but a non-judgmental safe space where we can talk about the fact that we have global concerns about sexual choking being a risk of harm, and where patients can ask us questions without being judged. So it's quite again, it happens in the context of a relationship. If you're able to take your patient seriously, listen to what they have to say, answer their questions about sexual practice as in as much detail as you are able to, and then that's giving them some really clear space to share their concerns with you and to maybe think about what they can do differently.
Yeah, thanks, Ellie. And Jamie, how might a GP assess for a brain injury?
Sure. So if it's a severe brain injury, I think GPs are acquainted with the signs and symptoms for that. But I suppose we're talking about more subtle forms of brain injury. The most reliable indicator of traumatic brain injury is a loss of consciousness or a change in level of consciousness at the time of the injury, as well as post-traumatic amnesia. So if the person can't remember the event during a particular injury, or if they have trouble knowing what happened in the seconds, minutes, or hours following the event, then that would be a very good screening question. The literature seems to indicate that it's actually common for the population that we're talking about to have sustained more than one injury. So asking questions about how many strikes to the head or how many blocks to the airway or choking incidents there have been over time, because as we mentioned earlier, the effects of those relatively minor injuries can stack up and cause significant cognitive impairment. So the way I would suggest that be asked is very, in terms of traumatic brain injury, is have you ever been knocked on the head and lost consciousness or felt dazed? Or have you ever experienced an event where you didn't have a memory for the seconds, minutes, hours, or even days that followed that event? So that tends to be a really good screener. That's held up in some of the research that we have done. Deteriorating levels of consciousness is a good indicator. It's also important, of course, to ask questions about whether or not the person has noticed a decline in their memory or thinking skills over time. So that decline can be stepwise, immediately following a very obvious event that may have resulted in a brain injury, but it can also be described as a gradual change, especially in the case of repetitive head trauma or non-fatal strangulation. And that's actually a requirement from a neuropsychological diagnostic perspective, in that there needs to be evidence of decline from a premorbid baseline to establish neurocognitive disorder. It's a mild neurocognitive disorder if it's subjectively reported but doesn't have a significant impact on day-to-day functioning. But if it does have a significant impact on day-to-day functioning, then the person's a candidate for a diagnosis of a major neurocognitive disorder, which would be a more serious type of acquired brain injury. So they're the key questions that should be asked to screen.
Thanks, Jamie. And if the GP identifies clinical indicators for a brain injury, what is the referral pathway for them?
Yeah, so I don't think there are very clear and obvious referral pathways necessarily, but in an ideal world, the person would be referred to a public service such as an outpatient brain injury clinic, obviously because that's free of cost. The clinic can then request relevant assessments to explore or delineate the presence and nature of any brain injuries. The private pathway is also available, but it's, of course, a lot more expensive. Either way, a neuropsychological assessment could be a good first step. And in terms of affordable neuropsychological assessments, many of the university psychology clinics offer them at significantly reduced cost. So that could be a good starting point if there is an access issue with accessing the brain injury clinics. So yeah, that they are the pathways that I would be thinking of to recommend in the current environment here in New South Wales.
Yeah. Yeah, and that's certainly something that we found on our project as well. When the women's health centres were creating their referral pathways, there certainly was a bit of a gap. Jamie, can you sort of explain what a patient should expect when they attend an appointment with a neuropsychologist?
Sure. First thing is there aren't enough neuropsychologists to meet the demand. So one should not expect an appointment tomorrow. Usually there are quite long waiting lists, and that's both in public health as well as in the private sector. So that's the first thing. Another thing is a neuropsychological assessment is a very time-consuming and intensive process. So the face-to-face component of a neuropsychological assessment typically goes for 3 or 4 hours. So it's probably the longest type of assessment anyone will ever have. And it's important that people are prepared for that and not to expect to have it all over and done within half an hour or an hour. The reason it's so lengthy is a lot of that time is involved in administering standardized tests and questionnaires, but there's also a significant clinical interview that takes place as part of a neuropsychological assessment. Obviously, being so long, it can be a bit of an exhausting process. So if the person is already struggling with fatigue or with sustaining their attention over long periods of time, they should let the neuropsychologist or the neuropsychology clinic know that in advance, because then the assessment may be able to be scheduled over 2 or more sessions. So that's an important pointer, because obviously the validity of the information gathered in an assessment is going to be compromised if the person is tired during the process. Having said that, breaks are offered during the neuropsychological assessment, and so don't be afraid to ask for breaks when needed. It can also be important to choose an appointment time that corresponds with the person's alertness levels. Some of us are more alert in the morning, some of us come alive in the afternoon. So try and schedule the assessment at the time when the person is most alert and willing and likely to be able to engage with challenging cognitive tests. Neuropsychologists consider other documentation as part of a neuropsychological assessment. So it's important to bring along any documentation, any previous brain scan reports or reports from other practitioners or hospital discharge summaries. They're all things that neuropsychologists find helpful, as well as a list of medications.
Thanks, Jamie. What I want to talk about now is the advice that GPs would give patients who have a mild brain injury caused by domestic abuse, and how that advice differs, for example, if the mild brain injury was caused by sports or a motor vehicle accident.
Yeah, I think in many ways the advice would be similar in that mild brain injuries can cause cumulative cognitive impairment. And whilst most people are expected to recover from a single mild brain injury, they do stack up. And so that would be advice that would be similar across the different types. In terms of non-fatal strangulation, as Ellie has mentioned a couple of times already, it's not so clear and obvious that that is a mechanism for brain injury. A knock to the head is. Most people can equate a knock to the head with then having some cognitive difficulties, but it's not as obvious when it comes to non-fatal strangulation. So I suppose emphasizing the fact that this is a mechanism that can cause lasting and in some cases moderate to severe cognitive impairments. So that's just part of educating the lay population as well as our patient cohorts about those risks. I think the other element that might be a little bit more different in terms of the advice presented to a victim survivor of non-fatal strangulation or mild traumatic brain injury for that matter is to particularly ensure that a trauma-informed approach is adopted, and that probably isn't necessarily as relevant to, say, sports concussion, but certainly it is more relevant in this population. And I suppose the other thing that might differentiate those different sources or causes of brain injury is there might be we're talking about risk of cognitive impairment, and I'm being a bit cautious because with terminology, but some risks are more preventable than others. So perhaps including some motivational interviewing, some psychoeducation, some support resources to encourage the victim survivor to think about how they might be able to minimize risk of ongoing harm from any future episodes of non-fatal strangulation. So they would be the main ways I think the advice may differ.
Thank you, Jamie. And we've been having this conversation quite a bit in the Pathways project at the moment because we're developing resources around mild brain injury. And I think we've certainly come to the same conclusion. It's the same advice, but how we unpack that with the client is very different. So, telling someone who plays sports, well, you can't do contact collision sport for 21 days until you're symptom free, but how do we relate that to women who are living in violent and stressful domestic settings? So is it possible to stay with someone you trust for the next sort of until you're symptom free for 21 days? Can you use your de-escalation skills if you think there's a fight that's about to escalate, even if it's not your fault? Yeah, so just those things in unpacking it as well. So I think also going back to what you mentioned previously, Jamie, about how there is a lack of low cost or free ways to access neuropsychologists and neurooccupational therapy for brain injury. Some of our women's health centres, they were able to use the victim support scheme to gain financial support for accessing healthcare services. And so in these situations, GPs, they can play a big role in supporting victim support applications by providing evidence and linking the women's experience of violence to her current health issues. Now, in saying that, applying for victim support is not a fix-all situation. Applications can take months to be processed, and not all clients are eligible. So, for example, if the assault doesn't occur within New South Wales, she's not eligible. She doesn't fit the criteria. It's also important to recognise that injuries sustained from engaging in consensual sexual choking, they're not going to be covered under the victim support scheme because she won't be classified as a victim in that situation. So, Jamie, if patients are unable to access other brain injury rehabilitation services, what are some ways that GPs can support clients with a potential brain injury while other means of accessing further health care services are being explored?
Yeah, my go-to resource is the Synapse website. So the Synapse is the Brain Injury Association, and they have some marvelous strategies, tips, information, pamphlets on the diverse range of sequelae of traumatic and other acquired brain injuries. So I would say to direct patients to that resource, or to even have some of those pamphlets or information fact sheets handy to give to patients. Probably more so in the realm of memory and attention strategies, because they tend to be very commonly complained about symptoms, or even brain fog or fatigue. So that would be my go-to resource.
Yeah, great. And I think when I think about that, we've certainly explored Synapse, and I think their resources are great. One of the big things that Synapse also advocates for is remaining connected, or helping establish connections to community and people, and that's certainly something our women's health centres can support patients with, because they run groups, and so they can support them making those connections, as well as one-on-one connections with counsellors and things like that can also support. So before we move into a case study, Ali and Jamie, what services and resources are out there to support GPs when managing patients with experiences of strangulation, sexual choking, and brain injury? And I know, Jamie, this is a double whammy. You've just shared Synapse, but do you have any more for the group?
I'll go quickly, because they are my go-to, but I just wanted to mention Synapse have a referral service too. So they can put individuals in contact with relevant practitioners based on the presenting problems or issues.
Great. Thanks, Jamie. Ali, did you have any services and resources?
Well, I think just we've talked about the health pathways, but also just kind of putting a shout out for reaching out to specialist New South Wales violence, abuse and neglect services and sexual assault services, because they can often see your patients, but they can often give really useful advice about responding to people who are experiencing violence, abuse and neglect.
Yeah.
We've popped so many resources. You guys have popped so many resources up here. It's hard to think of other things to add to the list. But
Yeah. Thanks, Ali. And as you would all be aware, because Sarah's doing such a great job of manning the chat there, we also have our project website, which is It Left No Marks. And so on that page, there is resources for healthcare providers, resources for service providers, but there's also an entire 2 pages actually for women. And on that page, it's been split into, so you have the option to go for strangulation and or sexual choking. So those 2 pages for women, they have different resources and they use different terminology as well. So let's go into the case study.
Hopefully
So
she's
I'll
back.
just share a little bit of context here. So for this case study, we have Opal. She's a 34-year-old first generation migrant from Lebanon. Opal is a mother of 3. So her oldest daughter is 1. Oh, sorry, her oldest daughter is 4 and her youngest daughter is 1. Opal moved to town earlier this year with her Australian-born husband. Opal is booked in for a sexual health checkup. When you welcome Opal into the room, she's wearing a hijab that covers her hair and her neck. And you notice her voice sounds husky. So, Ellie, as a GP in this situation, how would you begin to explore sexual choking with Opal?
Well, I think that what we're working with at the moment is hopefully I already know Opal. So, and I think that makes a huge difference. So I'm able to say, I noticed that you're sounding a bit husky today. If I've never met her before, that's going to be a harder conversation. I'm probably going to be asking about whether she's noticed any changes in her voice. There may, of course, be other reasons for being having a husky voice, but certainly if she's booked in for a sexual health check and her voice is husky, I've got a couple of intros into that conversation. So we can certainly note that we've noticed that she's sounding a bit husky. Has she got any soreness around her throat? Asking about local symptoms. And this is where I love using a bit of third person description and say, I often see this in people who've been choked or strangled. Has there been any pressure put on your neck? And so just kind of telling her what I've noticed. She's got a husky voice, what I associate that with, and then putting it back to her without saying, has this definitely happened to you? Just saying, often see this in that case, just wondering.
Yeah. And so you go through the screening process and Opal opens up to you and she tells you that her husband really likes to squeeze her throat when they're in bed together. And you confirm that she means during sex. Opal also says that he grabs her throat in an argument. He's grabbed her throat in an argument before. So, Ali, hearing Opal's response, how would you support Opal to make sense of this co-occurrence of sexual choking and strangulation?
Yeah, so I think that it's a really difficult one, isn't it? Because again, we've talked a lot about sensitivities around this. The first thing I would say to her is that I hold concerns about someone who tells me that their partner has grabbed their throat or is choking them. That I know that someone who strangles their partner using whatever language Opal's using, but someone who chokes or strangles their partner is just the statistics tell me that there is a high chance of lethality and serious danger in that relationship. So I say, it sounds, you haven't talked to me about violence at home, but this makes me really concerned because I know that men who choke their partners are more likely to go on to cause severe harm and even death. And that's not just by choking, it's just a marker of lethality in a domestic violence relationship. But we know again that's really just from a single study. We know from other studies that men who choke go on to choke other people. It's a thing. So I'd start by talking about the choking that's happening outside sex. Talking then coming back to the sex. So the other thing, as well as not disclosing strangulation, many women who are experiencing domestic violence will talk about the violence, but they won't talk about the sexual assault. So I will just start by saying to Opal that often there's some sexual coercion and, is sex with her partner consensual or not? Because again, sexual assault is a marker of seriousness in a DV situation. So if we're doing a risk assessment, then both choking and sexual assault are things I'm worried about. In this situation, I then start to think about what Opal's opinion on this is the sexual choking something that she's enjoying, or is it something she would like to stop? Is it a symptom of a broader issue within the relationship, or is that something that's just happening? We think it's probably not just happening in that context. So just start to explore some of those things with Opal, I think, at that point, but definitely be sharing with her my concerns that choking, especially outside the bedroom, raises for me.
Yeah. And I do apologize for the group. I've recognized the time. So we are going to speed this case study
Okay.
on just slightly. So, Ellie, you do a physical assessment, you ask some more questions, and Opal tells you that the last time pressure was applied to her neck was 3 days ago. Her throat has been hurting since yesterday, and her voice sounds husky. You also find some bruises underneath her hijab. So, no other symptoms. So, what you have is sore throat, voice changes, and bruises. What's your next step?
Well, I am now very concerned. She's had a recent strangulation event. She's got signs. So we know that most people who've been strangled probably don't have any signs. She has got some bruises there. So no bruises wouldn't mean no strangulation. And she's got a change in her voice. She's got a sore throat. I am going to refer her to the emergency department and explain my concern. So I'm going to say, I have noticed, also in her history, I would ask her about whether there was any loss of consciousness or any other neurological symptoms during or immediately after the assault. That's a really important question to elicit. So I would write a referral with all of the things I'm concerned about and refer her to the ED department. If possible, phone ahead, speak to someone, explain my concerns, and then really leave it up to them. But in a case like this, she may need imaging of the neck. And if she's got a possibility of laryngeal damage causing the voice and the throat symptoms, she may need an urgent referral to ENT as well. She may need imaging to look at the great vessels of the neck. And generally, that's a CT angiogram or possibly an MR angiogram. But that would really be the decision of whoever assessed her in the ED department. But I would be very strongly advocating for assessment and imaging within ED.
Yeah, yeah. And I think it's important to note here that we'd also be keeping children in view.
Yes,
Um,
yes.
and yes, and making sure that they are safe, and because children can be experiencing physical violence, including strangulation from the perpetrator as well. So Opal leaves your clinic, Ali, and she fails to attend for a scheduled appointment. She returns 3 months later. In this appointment, she tells you her and her children are still living with her husband, but now her sister and her sister's family are also living in the house until they find a new place to live. She tells her, she says her husband hasn't been violent since her sister and her sister's family have moved in. She says that she's happy at home, but she is worried because she's having constant headaches. She's got difficulty thinking, and she generally feels slow and foggy. So, Jamie, what support and advice can GPs provide to Opal in this situation?
Yeah, well, I think this is a key opportunity to provide some education around the fact that non-fatal strangulation can, in fact, cause cognitive and other neurological symptoms, such as those that she's reporting, and to to pose the question about whether or not there might be a relationship between those events and the symptoms that she is reporting. I would also suggest that the GP provide some documentation or refer Opal to a website where she can, at leisure in her own time, digest some of the information about the risk of cognitive impairment and brain injury arising from non-fatal strangulation, at least to sow the seed. One would be ambitious to expect that a person will just process all of this information and then accept all the services that are sort of recommended, but also providing some information about possible referral pathways to have some further exploration about whether or not there is some underlying cognitive or neuropsychological impairment, as I discussed earlier. The psychology clinics for a cognitive assessment, or the GP themselves might be inclined to administer a cognitive screening tool in the first instance and then refer on if necessary.
Thank you, Jamie. And I am going to hand over to Lauren now because I know she does want to share some information with the group. And I apologize if we didn't have any questions, but I can pop my email address in the chat here, and I'm happy to get back to you all as well. And just before I hand over to Lauren, I just want to say a big thank you to Ellie and Jamie for sharing your knowledge and your experience with us tonight. I know this isn't the first time that you've given your expertise and time to help improve outcomes for women. And I generally appreciate what you bring to this space. And of course, I also want to thank my colleague Sarah for manning the chat for us, and again, the PHN. So I think I speak for all of us when I say we share a common goal, and that goal is that there is no wrong door for women when they choose to disclose experiences of strangulation and sexual choking with us. So thank you all.
Thank you so much to all of you. That was just fascinating. And I'm sure everyone got a lot out of it. We do have quite a few questions. Just thinking, because we don't have a lot of time, do you want us to collect those questions and maybe we can send an email out to everyone with the answers? Would that work for you all? Okay. So we'll arrange, you'll be getting some post webinar emails with some additional information. So yeah, thanks again. That's been really great. I do want to take the opportunity just for the last 3 minutes to talk to you all about the Family, Domestic and Sexual Violence pilot that Nepean Blue Mountains PHN, Hunter New England Central Coast PHN and Central and Eastern Sydney PHN are part of, which is what has enabled the webinar to happen tonight. So this pilot, it has the aim to build the capacity of primary care providers to respond to domestic, family and sexual violence. So we do that in a number of ways. We can provide free training for your practice. So we can come to your practice or we can do it online. We want to make it as easy as possible for you to access that training. And we have 3 training packages, one on domestic and family violence, one on sexual violence, and one on child sexual abuse. And then on top of that training, we also have we have different names for it. Central and Eastern Sydney, we call ours the Navigator Service. Hunter New England have local links, and Nepean Blue Mountains have linkers. And we do have some in the audience tonight. So hi to the linkers joining us. So the role of the linker or the navigator is to support you when you have a patient experiencing family, domestic or sexual violence. So if you need some advice on how to have the conversation with them, your navigator or linker is the person that's available to you so you can have those conversations. If your patient really wants some extra support and wants to be referred, so you have that consent, the navigator or linker can assist you to make that referral. In some cases, certainly in our patch, they can take referrals directly. I think that's the case in the other PHN's areas as well. So it's a wonderful service, which really, I think, takes away the burden from the practitioner from having to do this work alone. You're not alone. This work can be really hard. So we want to walk alongside you and support you with it. So you don't have to do the running around to find the best support service. Your linker or navigator can assist you with that. So what I'm going to do in one of the emails you're going to receive, we'll list all the contact details for your local linker or navigator. So we'll send all of that through to you, and please, don't hesitate to contact us. We want to support you on an ongoing basis with this work. So we'll end it there. Thank you everyone so much. Thanks to our speakers. Thanks to Sarah for moderating the chat. Thanks to everyone that asked wonderful questions, and all the comments in the chat were really interesting. So thank you. You are going to see that there's going to be a little survey that comes up after the session, so please stick around to fill that out. For GPs in the Cesspin region, we will be able to do your CPD hours for you. If you're a GP out of area or another practitioner, you can self-report this training to get your CPD hours. But yeah, if you have any questions, please be in touch. Thank you so much. Have a wonderful evening. Please go and do something really nice for yourselves. Go have chocolate or ice cream or something, just to have a bit of a circuit breaker from this very heavy content. Really, really appreciate you having you here. So farewell. Have a good night. Thanks so much.